All right. So we're just coming on today, Dr. German. So glad that you're joining us here. We're super excited to kind of tackle this topic. I think it's a really fun one. I mean, it's not necessarily at the heart of what we do at an IVF center every day, but it's a very important thing in terms of what comes upstream to what it is that we do every day. So, um, Dr. German, this is your first time on the show with us. Of course, a core part of the New Direction Fertility team, one of the originals there with Dr. Amos. And so I would, I'll let you introduce yourself today, if you don't mind.
Sure. Hi, I'm Dr. Seth Thurman, and I'm part of New Direction Fertility. I'm in the Gilbert office. I've practiced for some time. I used to practice in Jersey for a long time. And I actually got to see patients for a long time at all ends of the spectrum. So a lot of my patients were actually just beginning their fertility journeys. I saw patients obviously doing IVF like we do now, but a lot of them were much earlier. So it was a discussion that I had very frequently because I saw people before they really had much of anything done.
Yeah, no, that's a great perspective. And, you know, as compared to maybe like a more conventional IVF practice nowadays, where there's four double board certified REIs working together, the four of us in the New Direction Fertility Centers. You kind of approach this in a slightly different way, and maybe you can tell us a little bit about that approach that you had and how you integrated with the OBGYNs, because probably patients, I'm guessing, started at some point where they were talking to their OBGYN and saying, "Hey, I'm just considering getting pregnant." How did that conversation look like?
Oh, what would happen is they would see their OB, and depending on who they saw, sometimes the OB would start their workup, and a lot of times they would just send them to me, and I would go through their history, start the evaluation, we start testing and try to figure out what's wrong, or just have a conversation. Well, you haven't been trying that long. This is the kind of timing you should be having. These are the kind of lifestyle things you should be looking at. So we had those, and I got to see patients really early. So a lot of them didn't need necessarily all these advanced treatments, although we did a lot of it anyway.
Right, right. So I think when we think about, optimizing natural fertility, one of the things that really comes to mind is exactly what you were just talking about there, which is, you know, fertility, as we all know, doesn't mean that a couple will get pregnant in their very first month of trying. Actually, what we know is that, especially compared to like other, let's call them animals out there, humans are actually kind of infertile at baseline, and so we're a little bit inefficient at getting a pregnancy started. And I think it's important to remember that, and that's where the definitions and the guidelines around when to even seek care come from. So, when we talk about couples in which the female partner is less than 35, we usually say that, short of any major abnormality that's obvious, we recommend trying for a whole year as long as you're having regular periods and able to have regular intercourse. And then at the end of that year, that's when we really kind of fire up the engines to do like the full workup. Now, there are some situations where we would do the evaluation before that point, but after the age of 35, the recommendation changes a little bit. We say try for 6 months. And it's not that people become more fertile after that point, but it's because there's a little bit more urgency around, getting an evaluation done after the age of 35. But I don't know, Dr. Derman, from your perspective, during that first year of trying, let's say a couple comes and during that first year of trying, they are interested in just doing everything that they can to optimize their natural fertility. What kinds of things do you recommend to them?
Well, a couple things. First of all, if they come early and they want to have a workup, I will certainly do it. So even though you don't really need, in someone who's younger, to do a workup earlier, they want to know if everything's okay. And once in a while, we'll uncover something that's a real barrier
Yeah.
to them getting pregnant, whether it be their tubes are blocked, sperm count's low, their ovarian reserve is low, whatever. And sometimes we will find things that are an issue. They sometimes patients just have this lingering feeling that there's something wrong. And sometimes it helps to dispel the concerns they have. One of the things, getting back to what you're talking about with the definition of infertility, most people think, well, infertility means I cannot get pregnant. And that's not true. Infertility means that you've been unable to get pregnant over a certain time, right? If you're under 35, it's a year. If you're over 35, 6 months. But it really doesn't mean you're infertile. In fact, when I'm discussing with patients about what about the pregnancy rates with IVF, with IUI, whatever we're talking about doing, I talk about, well, this is the background rate. There's a certain chance you're going to get pregnant every month, even if you do nothing. And that's particularly true for people who, who really haven't been trying that long. So we will do the testing if they want. If their periods are irregular, I'll start treatment right away. I'll start using fertility drugs immediately, even if it hasn't been long. We talk about folic acid. And one of the things I find is a lot of people have stopped taking their vitamins. And it's really, really important because they're assuming they can't get pregnant, or maybe taking the vitamins are a problem. There's nothing more important that you can do when you're trying to get pregnant than taking a multivitamin or prenatal with folic acid.
Yeah, yeah, absolutely. Which is a great point, and I just got a question about it over here, which is this question of supplements. And everybody's always, wants to talk about, what are the supplements to optimize, fertility and so on and so forth. And I think there are many different camps in terms of where we come from, in terms of the very proactive camp where you kind of take everything under the sun, and the very kind of hands-off camp where you just take a prenatal vitamin or something. This is a very interesting one, because I think that supplements should be directed for some reason. We shouldn't take supplements just like candy. I mean, they have potential side effects too, and potential harms, and they cost money and all these things. And so with supplements, there are some that may be helpful for certain conditions. For example, if a patient knows that she has polycystic ovarian syndrome, maybe considering something like myo-inositol would be a good supplement. Now, there are other things that you can do to optimize natural fertility, and we'll get back to that. But I know, Dr. German, you have some interesting supplements that, a lot of good evidence behind them. What kinds of things do you recommend?
Well, it depends on the patient. First of all, the folic acid, just so everyone understands, is not to help you get pregnant necessarily. It's really to prevent birth defects. We can cut the rate of spina bifida and those kind of birth defects in half by taking it. And that's why I want patients to take it. I'm not really sure it helps them actually get pregnant. Right. So that's number one with that. Now, the next thing is someone who has PCO, polycystic ovarian syndrome, or might have polycystic ovarian syndrome. We concentrate on supplements that help with their insulin resistance. When people have PCO, most of them have underlying insulin resistance as the cause for this. So you're talking about myo-inositol. I usually recommend ovasitol, which is a combination of myo and chiro-inositol. There's a lot of controversy as to which one's better, but certainly inositol is something I tell my PCOS patients all to take. And cinnamon is another thing that I'm really big on with that. Cinnamon you have to be careful with, though. Not eating cinnamon, but really about taking which kind of cinnamon you take. Standard cinnamon, when you buy cinnamon pills, is something called cassia cinnamon. And cassia cinnamon has contaminants in them. In fact, it has coumadin in it, which naturally occurs in the tree bark that they get it from. So I usually recommend patients take something called Ceylon cinnamon, Ceylon, which actually doesn't have those impurities. So you get the benefits without any of the risks. Just so people know, coumadin is a blood thinner, and it also causes birth defects. So if you were to take those, you'd need to stop them as soon as you're pregnant.
Oh my God, it feels like you've done a deep dive on cinnamon here. What kind of cinnamon do you guys stock at home? Do you stock a specific type of cinnamon at home to make sure?
Ceylon rather than standard cinnamon. If it says cinnamon, it's going to be cassia cinnamon. Now,
Yeah,
I'm talking about for supplements. I'm not talking about for what you put on food.
of
I think
course, of
the amount that you're
course.
going to get putting on food is relatively small.
Right, right, of course. And I was just joking, but that those are great. And how about antioxidants? I mean, sometimes we talk about, this role of antioxidants. Certainly for fertility, we've been very interested. There's a lot of research that's been ongoing about the role of various antioxidants, coenzyme Q10, N-acetylcysteine, things like acai berries, et cetera, acai berry extract. So the idea here, I have to say, is that we believe that some of these things may be helpful in a population of patients, women going through infertility treatment, IVF. There is no sound evidence that I would say supports the use for kind of optimizing natural fertility. I think there's probably little harm, but I always like to qualify that, because I think there's these big lists of supplements that exist on the internet, and a lot of them have been studied in some small capacity for women going through IVF or women going through fertility treatment, but not necessarily women trying to kind of get pregnant naturally. So I just thought we'd kind of touch on those things with supplements. Now I'll kind of turn it over a little bit to diet and just those regular things that maybe we take for granted, but are very, very important. And I got a question about this, about, what's the best type of diet to pursue as you're trying to become pregnant. And what are your takes on that?
Well, the best evidence right now for most people is the Mediterranean diet. I tell them if they want to go on vacation to Greece or Italy, that's great to enjoy it. But the important thing is that that you want a diet that's low in saturated fats, relatively low in carbohydrates. That those Mediterranean diets have been shown to be helpful for both IVF and in general for fertility. I mean, again, the data is not so clear, but there are multiple studies showing that. When I have patients with PCOS, I usually want them on a low carb diet.
Mm-hmm. Mm-hmm.
Keto, whether it's keto diet, South Beach, whatever low carb diet, because I think that definitely improves things for PCOS patients.
Right, right.
And also the supplements we give them and the drugs we give them, if they eat too many carbs, they're not going to do any good, because they're not going to keep the insulin level down, which is what we want. The other interesting thing about the supplements is in patients who are older. There are a couple things we recommend for people who are older who have low ovarian reserve. There's CoQ10, which may actually be good in everybody pretty much, and DHEA. So I tell patients who are older, I recommend that all the time. The problem is the science behind it is really not very good. But it's not, again, it's not harmful except in certain circumstances.
Right. Absolutely. So it's interesting, right? Because you mentioned there are some differences in what we recommend in terms of optimizing your natural fertility when it comes to diet, whether you have maybe PCOS or whether you don't. Maybe that's one of the big divisions that we think about. So for example, the Mediterranean diet, at face value, it's not that low in carbohydrates. I mean, it optimizes, green leafy vegetables and clean proteins and this kind of stuff. But the reality is it also has quite a lot of grains. Um, Whereas women with PCOS, just like you were saying, we kind of really try to uh, really, really go pretty aggressively on the low carb. And it seems to have a very positive impact on, the insulin resistance and the egg quality that results from those cycles. And there does seem to be a correlation with increasing pregnancy rates. Now, I want to take a little bit of a turn here, just because it's a interesting topic and we've seen it come up in the news a lot. And that's this topic of Ozempic babies, or kind of all these new medications that are leading some people to become pregnant while they've been on the medication. So I think the first thing that I want to make sure we say is that there's no good data on those medications in pregnancy. So we actually ask pregnant women to stop those medications, those medications like Ozempic. And those are the newer class of medications. But there are some very obvious reasons as to why these medications are working so well. The first of them is that they're increasing the insulin sensitivity, and patients are losing a lot of weight while being on these medications. It allows them to start ovulating normally and regularly again, which really is one of the things we're ultimately trying to do with everything when we try to optimize natural fertility, is getting a good ovulation, getting good insulin resistance, having let's call it the balance of some of these hormones in line with what leads to higher success rates. So it's not unusual that people are starting Ozempic, these things, losing a bunch of weight, their insulin sensitivity gets better, and then here they are pregnant, 3, 4, 5, 6 months later.
I think I think Ozempic and those kind of drugs are going to be a huge boon to fertility. The only thing that's frustrating about it is we're not sure that it's safe, and there's evidence that it might not be safe at all. So, I tell my patients it's okay to take it, but I want you off of it a month before you're pregnant.
Right. Right.
And we don't know. It's a shame that you couldn't take it until you have a positive pregnancy test, but we just don't know if it's safe, and that's the problem. I've had patients in the past who've undergone weight loss surgeries, which kind of achieve the same effect, but obviously with a major surgery, and their fertility has gone amazing. I've had patients who can't get pregnant no matter what we do IVF, they fail. They do they lose the weight from the surgery, and then all of a sudden they can get pregnant very easily, either with treatment or sometimes even without.
Right. What about this? What are your takes on exercise? Right. This is a question we get a lot, and can there be too much of a good thing? Can there be too much? Too
Oh,
much?
absolutely, yeah,
Okay. Tell us
absolutely.
your perspective on
But
that. Yeah.
everyone has a definition of what too much of a good thing is, though, right? So I tell patients a minimum of 20 minutes 3 times a week, and that's really a minimum. I mean, more than that is actually better. But people who exercise excessively, people who are out there, training for marathons, it actually can have an adverse effect on their fertility. So moderate exercise is good. Too much is really too much.
Yeah. Yeah. Too much can, I mean, even, lead to women not having their cycles regularly, not ovulating regularly. Now, interestingly enough, I've seen this on both sides of the spectrum, with some guys as well who are, super ultra marathoners or endurance athletes or marathoners, very competitive levels. It can impact the communication between the brain and the testicles in such a way that sperm production can be compromised to some extent. It can also lead to, having an elevated temperature for the testicles, especially for people like cyclists, where a sustained elevation in the temperature can actually be really poor for the sperm, can lead to bad quality sperm. So definitely too much of a good thing is a very real thing for fertility. One kind of additional piece that's interesting about this is that we know with fertility, we have what's called a U-shaped curve. So at both ends of the extreme, we see slightly lower pregnancy rates. And as you get further and further and further from kind of that sweet spot in the middle, you get, again, lower pregnancy rates. And so what we're talking about are women generally below a BMI of 18. That's kind of very, very low body fat percentage, which you tend to see in some types of athletes. And then on the other side of the spectrum is, of course, with increasing BMI, we can have some of the issues we talked about before. So yeah, those are definitely all very important ways in which, natural fertility can be, improved. And again, if anybody wants to come on to the show and ask some more questions, we've just had some kind of texted in that I've taken on the call here today. But if anybody wants to come on the show, we'd love to have you on and and love to have you obviously join the raffle and the opportunity to win some things here at New Direction. So I did see a question here from Shauna, and she was asking, what are the options for InvoCell? Or maybe we could talk in a little bit more detail on InvoCell. So I'm happy to take this one, or Dr. Derman, however you'd like.
Well, we do InvoCell here. When we're doing InvoCell, we tend to use a lighter, very much more gentle stimulation. I don't know how familiar you are. Shauna was the person who asked how familiar you are with it. But what we do is we stimulate people kind of like we would do for insemination, so we don't get nearly as many eggs. And then we get the eggs out, the sperm. We put them in the InvoCell device and use that as the culture. Instead of it going in an incubator, we put them in there, allow them to culture in there, then take them out and do the transfer. So we do those, and we do have availability of that. Keep in mind, it's not as effective as regular IVF. There's a lot of things that we can't test for, but we've had a lot of success with it in our clinic.
Yeah, absolutely. So just a little background for everybody watching who might not be familiar with this technology. It's a specific, let's call it an intermediary, right, between kind of like a IUI and an IVF. It has higher success rates than IUI, lower success rates than IVF. And it's a process in which we grow a smaller number of eggs. It's a little bit of, let's call it like a more gentle protocol. We still retrieve the eggs like we would for IVF. And then we pair the eggs and the sperm together in a capsule, in a baby pod, if you will. And we put those together in the capsule. The capsule is then incubated in the vagina for approximately 5 days. And then it's taken out. We see the embryos that have been created, and the embryos are put back into the uterus in a fresh embryo transfer right then and there. So there are some advantages to it, beyond some of the things that I've already mentioned there. Obviously, one of the huge benefits is that it may be more cost effective for some couples. And I think for the right couple, for the good candidate couple, it's a very, very good technology, and something that we're really excited that, we have, and a few other centers, do this type of thing as well. And so I think it's a very interesting technology. I want to see more from it. I would hope to see that the device continues to be improved upon, and that maybe we have even better quality embryos that are come as a result of the InvoCell environment. But again, depends why we're treating the infertility, but for certain groups of individuals, it may be really beneficial, or, to at least ask about it.
And it's certainly much more cost effective. So
Exactly.
some people decide to do that because it is less expensive. I mean, like I said, for certain things, it's not as good, but it does work better than IUI.
Absolutely. And I know we did have some questions from our last show. And I thought, there was a couple of them that are just general IVF questions. We'd love to take any questions from folks watching. So one of the questions was about discarding embryos, and what the process looks like to discard embryos. And I thought I would just talk about that, a little bit. And Dr. Derman would love to hear kind of your take on it as well. So I think the first thing I want to start with is saying that discarding embryos is a process that we take extremely seriously in the world of IVF. And every IVF center takes it very, very, very seriously, meaning that it is a process in which decisions have to be made well in advance. Those decisions have to be signed off by the responsible parties that own the embryos. That is your property. Those embryos are your property. And so and then if the decision is made to discard an embryo, they have to be signed off on having them being discarded. And then they are discarded sometimes at a slightly later date, because the process of discarding is very sensitive. The embryologists have to double and triple and quadruple check everything to be 100% certain that they are always discarding what was agreed upon. And so discarding doesn't necessarily happen on the day you sign to have it discarded, but it will happen shortly thereafter. So I think that was, getting at that question. But Dr. Derman, what kind of thoughts did you have about that question?
Well, the other thing is, I think people need to understand is a large portion of the embryos we're discarding are embryos that are genetically abnormal, embryos that have really no chance of surviving. And so when patients have PGS and we test your embryos, there are a few things that we can find that are abnormal and would result in an unhealthy baby. Most of the things that we find are things that will never result in a baby. In a small portion, they might result in a miscarriage, but most of the time, there's no chance. So that's most of them.
Yeah.
And then a small portion of them are, people who have extra embryos and don't want to hold on to them. But again, it's a very, very serious process. There's multiple people checking to make sure. I don't know what the frequency is, but the lab has their own protocols for that, how they handle
Right.
that.
That's right. That's right. So I know we're talking again about optimizing natural fertility, and we're getting some people asking a variety of questions. And we have a very good question here, and one that a lot of people have, which is, when do you know when to move to IUI, and how does IUI work? And I thought maybe Dr. Derman, maybe you could get started with that, and maybe give folks a little bit of a background on how you counsel people from going from that trajectory of, hey, you were trying, you've maybe been trying for a year, and now we're going to go over to trying IUI.
Okay, so first thing we do obviously is make sure all the tests that we need to do are done. Sometimes we'll skip that, but most of the time we'll do all the tests, make sure the tubes are open, make sure the sperm's okay, make sure that your ovarian reserve, the FSH, AMH levels are good. So we do that first. The next thing I usually do is have a conversation about what the options are. Okay, rather than in most situations, rather than saying you absolutely have to do this or you absolutely have to do that, we have a discussion about what the options are. And those options are usually IUI and IVF. And we first talk about what the chances are, right? So you have to understand what your chances are naturally, what your chances are with IUI, what they are with IVF, etc. So then we have a discussion about the process, about what's involved in IUI, what kind of drugs we would use, what the pregnancy rates are, the multiple birth rates. And then we also would have a discussion about IVF. And then after balancing those things out, we let you reach a decision on your own. There are certain circumstances where really IUI is a waste of time, but a lot of times it's totally reasonable to go either way. But it's really important to us that our patients understand fully what the options are, how they work, what the reasons to do one over the other. And it's not a, well, you definitely should go this way. Sometimes it is, but most of the time it's not.
Yeah. One of the things that I like to think about with IUI is, I always say it's aligning the stars. We're basically trying to optimize everything so that the sperm can meet the egg in the body under the optimal conditions. So what are we doing? We're trying to have one or two follicles, maybe three follicles grow at the same time. We're trying to make sure that the endometrial lining is sufficiently thick and looks to be trilaminar and kind of receptive for an embryo to implant in it once we are at the stage where we're going to be doing the IUI. We're also looking to make sure that the follicles are of an optimal size and kind of optimal for the fertilization process to have a higher likelihood of working. So I think when we look at all of these things altogether, IUI is really trying to very, very much optimize the chances of success. We typically see IUI success rates per cycle in the range of 15 to 20% per cycle. It is dependent, of course, on age, a few other things, but that's kind of a ballpark. Now, the way IUI works, of course, is that we give some very low dose medications, usually for 5 days. And then you would come for a couple ultrasound visits to make sure that those follicles are growing, everything is going well. And then we trigger the follicles to release. So you have the ovulation event happen. And then we take the sperm in the lab, we concentrate it down to the best swimmers, and we put that concentrated bit of sperm directly into the uterus at the very top of the uterus to where they have the shortest distance to get to the egg, right when the egg is coming in as well as it's ovulating, right when the uterus is ready. And we've kind of, in my words, we've kind of optimized everything to happen kind of naturally with a little nudge. And so that's the process of IUI. And I think that was Shauna's question there.
Yeah, I kind of look at IUI, I always refer to it as a shotgun therapy. We're throwing more eggs, more sperm, the right place, the right time, and hopefully, and we do, increase your chances. The only thing is with IUI, you don't necessarily know when it didn't work, why it didn't work. Now that's okay, but it's important to understand that. I always have the discussion because people go through IUI and they don't get pregnant. And sometimes we have an answer like the sperm count's lower or whatever, but most of the time we just don't know. We just know that the rates are much lower than with other things. But it does work and people get pregnant with IUI all the time. But we don't always have an answer why it worked.
Right.
Or why it didn't work, more importantly.
Absolutely. Absolutely. We have some other questions coming in here. So this is a question from Madison. If you did IVF due to PCOS, could you still get pregnant naturally? Meaning, would IVF hinder your chances of getting pregnant naturally? And so this is a great question, Madison, and maybe I'll take a stab at it first. So I think if I'm hearing your question right, you've done IVF, you had PCOS in the background, and maybe the IVF didn't work. And the question is, would it be possible to still get pregnant naturally? And the answer is generally absolutely yes. Doing IVF does not decrease your fertility in any way. And I think there's sometimes this misconception that, oh, I have, maybe 10 eggs in my left ovary and 10 eggs in my right ovary. And then we took all those eggs out and now I'm not going to have those eggs anymore. But those are eggs that your body would have naturally gotten rid of that month anyway. So in other words, your doing the IVF cycle doesn't reduce the number of eggs that you have overall. The other part of it is that doing IVF doesn't decrease your chances of getting pregnant in subsequent months. We, of course, know from our own research that there are many people who may not get pregnant with IVF and then later get pregnant naturally, or maybe their first pregnancy is with IVF and then get pregnant with their second baby naturally. So we know that that's the case. We know that IVF doesn't hinder the chances of getting pregnant naturally. What's your take on that, Dr. German?
The other thing to remember is when we're doing IVF, a lot of it is not really natural. I mean, I'm sure that doesn't come as a surprise to most people, but we're pumping you up with large doses of fertility drugs, which for most people will be good because we get more embryos. But sometimes we push them too hard or too little. And what we're seeing in the lab, as far as the embryos and whether you get pregnant, for the most part, we're improving things. But in some people, the drugs can actually make things worse. Like I said, I don't want you to think that's common, but it does sometimes. And sometimes we'll learn things. Like, for example, I've had patients where I didn't suspect PCOS at all. And I go through their cycle and they respond exactly like somebody with PCOS. So we start putting them on the supplements. We talk about diet and stuff like that. And a lot of people will get pregnant just from the things that we learned from the IVF cycle. Because those were really important things and things that weren't obvious from the testing that we did before. But I've seen this many times where people have either gotten pregnant from IVF with PCOS or not gotten pregnant and then gotten pregnant on their own.
Right. Absolutely.
Absolutely.
So we're seeing a couple other questions here. So I'm going to try to get to everybody's question. I think this is an interesting one. What's the minimum sperm count that would be needed for IUI? And again, this is one in which there is a lot of research that's been done about it. It's also a question that's a little bit tricky to answer perfectly. So there are numbers above which it's ideal. So we generally say above 8 million total motile count is generally considered ideal for an IUI in that group of sperm that you put in there. And then there are numbers below which we'd certainly see the success rates really start to drop off for IUI because the sperm counts are so low. Those numbers vary depending on the study that you look at, but I think there's probably some consensus around 4 to 5 million sperm, that once you get below 4 to 5 million sperm, you're seeing lower rates. Now, can you get pregnant with IUI with a total motile count of 1 million? Yes, you can. It's just that the efficiency with which that happens is pretty significantly compromised. And that's when we start to generally have a conversation. Maybe we've done 2 cycles of IUI, consistently having lower sperm counts than what would be ideal. And we say, hey, maybe this is now the time to start thinking about another treatment, because the sperm counts are making it so hard that really it isn't ideal to go through IUI anymore. But maybe you have some different numbers. I'd be curious to hear what you have to say about that, Dr. Derman.
Well, kind of my take is that the pregnancy rates go at about 1 million is where you start seeing pregnancies. And from about 1 million to 10 million motile sperm, the pregnancy rates increase. And then once you get above 10 million, it doesn't matter whether you have 10 million, 100 million, the rates are pretty much the same. That being said, I did see many years ago, I had a patient who had 500,000 sperm, and she got in her IUI, and she got pregnant.
Oh my gosh, strong sperm there.
Happened. It's not likely.
Yeah, that is definitely unlikely. Wow, that goes to show you that you don't need many. I mean, that's so low, 500,000. Wow,
yeah. I mean, it's very unlikely, and I generally counsel patients if there's less than 1 million, it's probably it's very futile doing it. But I have seen it once.
Right.
I was really shocked that she got pregnant, to be honest, but she did.
Yeah, no, that's great. I mean, by comparison, I think this is interesting for our listeners and our viewers. With IVF, we talk about with IUI, you need at least, this million to 4 million, with that little bit of a linear relationship as you get to about 8 to 10 million. But with IVF, you really need, I mean, very technically, just as many sperm as you have eggs, because we can use the process of ICSI to fertilize a single sperm with a single egg. So you can use extremely low numbers of sperm and still be successful with IVF with the use of ICSI. And that's a big difference between IUI, because with IUI, beyond a certain number, I mean, it's almost kind of getting to the point where it's pointless to do IUI. And that's where IVF, and especially since the introduction of ICSI, it's made a huge difference. We've got another question here, since we're on the topic of IVF. Somebody's asking if there are higher chances of getting multiples with IVF versus naturally conceiving. And this is a kind of a lot of questions in one. Would love to hear your historical perspective. So, what did IVF look like 25 years ago, if somebody would have asked the same exact question? And let's compare it with today.
Well, if you asked me this question when I started in practice, I would have told you there's a 25% chance at least of having multiple births, including triplets and even quads. Nowadays, it almost never happens. Yeah. Because what happens is we used to transfer 4 embryos in people routinely, in young women routinely, because the pregnancy rates were terrible with IVF. A good center ran a 30% pregnancy rate. And they did that by putting back 4 embryos in people. Now we run a 62% pregnancy rate, putting in just 1.
Yeah.
So IVF is actually, right now, unless you have us put in 2 embryos, your rate of getting multiples from IVF is less than doing IUI. It's like 1/5 actually of what the pregnancy rates are with letrozole, and so it really makes a big difference. So IVF works better. It's less likely to get to multiple births. And of course, it's much more involved, but in terms of the multiple birth risk, it's like night and day.
Right, right. Yeah, it's incredible. I mean, it's just amazing every time that we talk about historically how high the multiples rate were and how low the success rates were. And now we've really flipped that paradigm upside down. And I think this is probably one of the biggest innovations in reproductive health is the fact that we have these phenomenally high success rates while we've made mom and baby much safer by transferring a single genetically normal embryo each time. And compared to, you know, how IVF used to be done when you just had to take a little bit of a gamble on it. And you said, well, I hope the multiple rate won't be too high, or maybe it's just twins or something like that. But even twins have a much higher obstetric risk, higher rate of delivering preterm, so on and so forth. And so I really believe that the safest thing for a mom and her baby is a singleton pregnancy. And to answer your question, you know, is there a higher chance of multiples with IVF versus naturally conceiving? There is technically still a little bit of a higher risk. The first reason is that we almost always transfer one embryo, but sometimes we do transfer two embryos in certain circumstances, and that can happen. The other thing, though, is when we transfer one embryo with IVF, it has a slightly higher chance of splitting and giving us what are called identical twins, of course. And that is a little bit of a higher chance of that happening than what happens in the natural world. And so I think that is a little nuance. Still, the risk is about 1% of that happening. So it's pretty low.
Yeah, we're manipulating the embryos when we do IVF. I mean, we try to keep that to a minimum, but that's essentially what IVF is. We're taking your eggs out, we're fertilizing with this. There's all sorts of things that don't happen inside your body. So that's why there's about a 1% risk. But it's 1% is pretty low.
It's pretty low. That's pretty, especially when we compare it to what you were saying before. What was it?
Oh, 25. There were clinics that had 50% multiple birth risks.
Oh my goodness. Oh my God. I remember seeing an old Time magazine or something like that, and they were showing pictures of a specific town. I can't remember where it was, but I think it was
Bedminster, New Jersey.
There we go.
I know because some of the clinics near where I used to practice were up there, and what was happening is IVF was getting better. They were perfecting IVF. And at the same time, we were still putting in a lot of embryo. Well, they were doing that, but they were putting in a lot of embryos. And as a result, the two clinics had their main offices very close to this area. And they had the highest rate of triplets in the entire country. And at the time, now we would think that's a problem. At the time, it was because, you know, they were doing a good job.
Right.
Now
right.
we can do a great job without this.
Absolutely. Well, this is great. We have another question here, and this is kind of a fun one. When it comes to gender, is gender based off the father or the sperm source, or is it based off the mother's contribution of the egg, or is it just totally random? So this is one of those kind of fun genetic things. So of course, you know, the fathers, the sperm source will have a chromosomal makeup of 46XY. That means they have one chromosome that has the X chromosome, one that has the Y chromosome, and then in each individual sperm, there's either the X or the Y. Mom is going to always contribute an X chromosome, and then when it pairs together, it'll pair about 50% X with X and 50% X with Y. So to answer this question, the sex is kind of determined by the sperm, but I assure you the mother determines like pretty much everything else.
Well, it's not really so clear. Certainly, which sperm gets in, which depends which, you know, from the father, obviously, determines whether it's going to be a boy or girl. But there's some question as to whether the egg determines which sperm gets in. And we don't really understand it fully. It may be completely random. There may be something going on with the egg that allows certain sperm to get in. I mean, everyone knows families where, you know, you have all boys and you have all girls. My family, my generation was all boys. The next generation is all girls. But we don't really know. We don't really understand if there's a reason, or when you flip a coin, you can get tails 5 times in a row or heads 5 times in a row. It's
Right.
just as likely as any other combination. So
Right. Well, it's certainly fun to think about it. It's fun to think about, maybe there are more levers out there than the science fully understands at this point in terms of how does the egg sort of choose the sperm, and definitely, that could, in some respect, maybe the egg does pick a little bit which sperm gets in, and the sperm just holds that specific chromosome. So very interesting. And a great question. Well, I think we're kind of starting to come up on our time here for today, but it was a really fun conversation about kind of optimizing natural fertility, really having a sense of some of those basic things that everybody can do to have higher natural success rates, and at the right time, if you've done those things, if you've exploited those things, and you're still not pregnant, it's best to be proactive and to get a thorough evaluation and things like that. And Dr. Derman, any ideas there on your end, or anything that you would love to? Oh, I think we have a last minute question here from a caller here. So here it is. If twins are so risky and IUIs have a higher risk of twins over IVF with single embryo transfer, why do insurance or REI practices allow IUI but only allow single embryo transfer? Well, this is a really very insightful question. Dr. Derman, do you want to get started with this one? Do you want to take this one on?
it's mainly because they perceive it as being less expensive. Right. So an IUI is anybody who's gone through this knows that IUI is a much less expensive procedure to do than IVF. Years ago, when we used to get triplets all the time, I kind of did the math, and I figured, based on the volume of patients that I was seeing at the time, that if I had a patient who had triplets and delivered at 32 weeks, let's say, the amount that the insurance company would spend on the newborn care and the NICU for these babies is more than they paid me for everything I did for an entire year. So the insurance companies really should be encouraging people to do IVF and not do IUI, and encouraging them to do single embryo transfers.
Right.
I think that they see it as a way of, avoiding having to pay for IVF. But in terms of avoiding multiples, I think it makes sense to do IVF and do single embryo transfers.
Yeah. Yeah, it's a great point. I mean, I think there's another part to all of this too, just to take another step back, which is, most twins do fine. The vast majority of twins that are born do great, and they do very, very well. It's just that the relative risk of twins compared to singletons, or a single pregnancy at a time, is significantly higher. And so insurance companies are very much starting to mandate that IVF doctors only transfer a single embryo. And in order to do a single embryo transfer with very high success rates, it's much easier to get there with genetic testing of that embryo. So it's a very complex interplay of different people who are interested in this. So just like so many other things, whenever insurance companies are involved, they're going to have their own interests. And those interests may or may not always be exactly the same interests as the patient. And so that's where I think it's good to have an honest conversation about all these things. And so sometimes the risk of twins with IUI is acceptable because that's what's better for the patient. IVF is still a procedure. It still has some intervention. It still has all these things. At the same time, with IVF, we can at least try to reduce the risk of twins by doing genetic testing in a single embryo transfer. And just like you said, Dr. Derman, if we can do that, we can really try to optimize things for the patient, downstream for her delivery.
The other thing is, with IUI, we tend to use now drugs that have lower multiple birth risks because we know IVF is so safe, so effective, and has such a low multiple birth rate. So, for example, I used to use a lot more Gonalaf and Folliston in IUIs. And now it's like, well, why would I do that and put a patient at risk for triplets?
That's right.
When IVF used to have triplets all the time, it's a different story. But now IVF is actually safer.
Yep. There was a really interesting group of studies that came out from the NIH group, uh, the group out in Bethesda, of course, and they showed that the highest rates of twins and triplets in the country right now, just like you said, are coming from IUI, not coming from IVF. Now, a little kind of side note on this and a little bit of trivia, as everybody may well know, the IVF, the CDC tracks IVF rates across the country, and they really keep a very close eye on the twin rate, the triplet rate. But nobody keeps track of the IUI twin and triplet rate, even though that's where we know most of those are happening, much more so than with IVF nowadays. And so it's just an interesting bit of trivia, getting back to this question that we had here earlier.
Well, the IVF tracking and tracking the pregnancy rates and so forth began in 1992 when there was a law passed requiring that clinics either report or be listed as non-reporters. So IVF has been mandated to be reported, so we know what they are, and everything's very open. But there's no such regulation when it comes to IUI, and a lot of IUIs are actually being done by people who aren't reproductive endocrinologists and don't really have an understanding of that.
Right, right. Absolutely. Well, these are all phenomenal questions. These are excellent questions and a really great general topic to talk about. And people came with, just like a whole host of really fun questions today about everything from what determines a girl versus a boy embryo, and the risks of IUI, twins, chances of getting pregnant with IVF. We talked about InvoCell. We talked about how IUI works. We talked about a whole host of things here today, but thank you so much, Dr. Derman. I just love talking with you. And, one of the things I love hearing from you is, you're so current with everything right now, of course, but you have that perspective of how things were done, a little bit before I came onto the scene. And so I really appreciate that.
Can I add one thing, since our topic was about planning for pregnancy?
Absolutely.
If any of you out there have a partner who's on testosterone, get them off of it immediately. That is
great.
The worst possible thing that you could do for fertility is having your partner take testosterone.
Completely agree.
Almost anything except tying your tubes, maybe, but that's about it.
Mm-hmm. And there are a lot of gentlemen out there on testosterone, and I think they're not counseled appropriately, but there we go. Another topic, another way to optimize your natural fertility. Don't get on testosterone. I think that's a kind of a highlight to end on. So we'll go with that.
Thank you.
All right. Have a wonderful night, everybody. And thanks for joining us here today.